Good evening, everybody, and welcome to our webinar today with the FRCS Mentor Group. Today, we have Mr. Al-Hussein Al-Gungihi. He's he's Prof. Al-Hussein Al-Gungihi. He's Professor of Pediatric Orthopedic at Ain Shams University in Egypt. He moved to the UK recently, about 2.5 years ago, after clearing his FRCS, and he's working in the Northwest at the University Hospital of Morecambe Bay. So today he will present us with his best way for the shoulder and elbow examination for the FRCS exam. This should take us about 30 to 40 minutes, followed by questions. And after that, we'll stop the recording. And as you know, we'll start our Viva practice. So I'm handing now to Prof. Hussein. Thank you.
Thank you very much, Hussein. Thank you. Hi, everyone. Today I'm going to talk about shoulder and elbow examination in terms of FRCS exam, the clinical exam. To be honest, the FRCS exam is a little bit tricky in terms of time management. So I'm sure that everyone knows how to do shoulder examination, how to do elbow examination, go for the diagnosis and everything. But the point that you need to do that within a few minutes. For instance, if you have a short case, you might face about 5 minutes, and within 2 or 3 minutes, you got to have some sort of provisional diagnosis. I have a certain technique for doing the shoulder and elbow examination so that you will be able to spot the most common diagnosis. So I'm going to share my screen. So if you are going to talk about shoulder examination, we are going to, first of all, the position of the patient. So for instance, once you see the patient, if the patient is sitting, shoulder examination should start in a standing position. Why is that? Because you got to have a look at the scapulothoracic articulation during the movement. So position, good exposure, screening. So we start with look, feel, and move, then special test. We all know that. So when you start looking at the patient, you got to start looking from the front, from the side, and from the back, and start to talk. I mean, you got to tell the examiner, I'm going to compare the shoulder from the right side to the left side. I'm going to have a look at the shoulder contour. If there's any scars, it will take a few seconds. Then do not forget the Excel. Have a look at the Excel. I'm not sure there is hand raising, Hussein. So I think we are going to do the questions at the end of the.
Yeah, they just raise their hands they are very keen to be asked. So just taking their place in the queue. So just continue, no problem. Yeah.
Okay, so after looking, you got to go for feeling. For the palpation, sometimes the candidate is wasting his time. I'm going to look at the stereoclavicular joint, the clavicle, EC joint, back to the spine of the scapula. I want to keep it short. The most relevant, all of this is irrelevant. The most relevant for palpation is the EC joint. So tell the examiner, I'm going to palpate the EC joint. Sorry. So I'm going to examine the EC joint for EC joint osteoarthritis. So palpation, the most relevant is EC joint palpation. Then we'll go for movement. We'll start with active movement. Why active movement? Because it's very important to see the patient range of motion if there is arc of pain. So if you rush for passive range of motion in the very beginning, you might hurt the patient because you don't know which is the painful arc. So start with active range of motion. How are we going to tell the patient? You're not going to tell him flex your shoulder, abduct. Just tell him, follow me, please. So you'll just telling the patient to imitate you. So we'll do flexion, abduct flexion, in the scapular plane, then abduction, see the active range of motion until over his head. You will do these positions from the front and from the back. So you will tell the patient to do the movement from the front, and then you will go to the back of the patient and tell the patient to do the same movement so that you will have a look at the scapulothoracic articulation. And while you are on the back, give also a screening for the spine, cervical spine. You can do that as well during inspection. Then you have remaining. So you have done flexion, abduction, and then you have internal rotation and external rotation. For the internal rotation, there is two types of internal rotation. The functional is the most important for us. And what is the functional internal rotation? Functional internal rotation is simply telling the patient to put his hand behind his back, and then you record whether he can reach the greater trochanter, the buttock, the sacroiliac joint, L5, L4, and so on. So this is the functional internal rotation. External rotation is the only movement which you will do it passively. And this is very important. And this we got to stop, because external rotation will give you a clue. So you have two important diagnoses if the patient have limited external rotation. You have adhesive capsulitis and osteoarthritis of the shoulder. So this is the most important two diagnoses if the patient have limited external rotation. And of course, you got to compare with both sides. So you got to highlight it in your mind. Once the examiner and once the patient have limited external rotation, you got to know that it is either osteoarthritis or adhesive capsulitis. How could you differentiate? Definitely by an X-ray. Adhesive capsulitis will be normal X-ray, and osteoarthritis, you have all the findings of osteoarthritis on the X-ray. The third diagnosis is a locked posterior dislocation, but it is usually unlikely you'll have this in the clinical exam, but you might be asked in Viva exam. So this is the active range of motion, and then you go for passive range of motion and record the range of motion in terms of your passive examination of the range of motion. So now you have a clue if the patient have limited, for instance, limited elevation, you have painful arc, you have limited external rotation, you have something in your mind. You might have impingement syndrome, rotator cuff problem, and then you will confirm with the rest of the examination. For me, I will go after doing the range of motion. For me, I will go straight away for special test. The most important three impingement test is the three. You can do it only in one move. So I will stop sharing just to show what I would like to say. So for the impingement test, you'll do three movements. You'll do the near sign by elevation and internal rotation, and you'll do Hawkins sign and scarf test. You'll do it in a few seconds. Elevate the patient, elevate the shoulder. This is near sign, Hawkins sign, scarf test. Within one movement, you will have a clue. So this for the impingement test. There is other two impingement tests, but to be honest, they are not sensitive and not specific. Like the speed Ergson test, probably they are not of the importance of the three impingement tests which I just demonstrated. So the impingement test, you will do it within a few seconds, which is near sign, Hawkins test, scarf test for AC joint, within one movement. So of course, we know the near sign. Maybe I'll ask you near test. Of course, near test, you all know it by giving a local anesthetic injection and repeating the test, the pain will subside. Hawkins impingement sign and scarf test. And of course, we know the scarf test. O'Brien test, actually, it's not sensitive, not specific if you have a look at the test. So it's simply to detect slap lesion. It's not that important. You will resist the hand of the forearm of the patient while internally rotating the shoulder against resistance. And then the speed test, also not specific and not sensitive. It is for biceps tendonitis. flexion of the elbow against resistance, putting your finger on the bicipital groove. And then we got to do, which is one of the most important for shoulder examination, is the rotator cuff muscle. Rotator cuff muscle, of course, all we know it. You have the supraspinatus, infraspinatus, teres minor, subscapularis. You got to know the nerve supply, suprascapular nerve for supraspinatus, infraspinatus, teres minor, axillary nerve, and subscapularis, upper and lower subscapular nerve. And why this is important? Because it's important in case of brachial plexus injury. And we are going to talk about this in a separate presentation. Supraspinatus test, empty can test or JOPAS test, you will put the patient in internal rotation, abduction 90 degrees, and then resisted, you are going to push downward, ask the patient to resist your hand. And why you're putting the shoulder in internal rotation is actually to put the supraspinatus muscle in the best action, best advantage, because the muscle fibers will be online with the insertion, at the same time putting the deltoid muscle in position of disadvantage. So supraspinatus test or empty can test, you got to know why you're doing it, how you do it, and why you're putting the position of the hand in internal rotation. Then you have infraspinatus test, you put the elbow on the trunk and resisted external rotation, and at the same time put your hand or your finger on the infraspinatus fossa. Then we have the hornblower sign, which is for teres minor, abduction, external rotation, and the resisted external rotation. If the patient cannot maintain the position, this is positive for teres minor. The last muscle is the subscapularis muscle. You have two tests for subscapularis muscle. You have the Napoleon test, press belly test for subscapularis. If the pectoralis major is recruited, it pulls the humerus and brings the elbow back. Therefore, keeping the elbow forwards requires only recruiting subscapularis. That's why this test is recruiting subscapularis muscle. And we have the lift off test. This is the twist test for subscapularis. As we said, the biceps examination as well. The Yergesim test is actually resisted supination, pronation while checking the end of the patient to see if there is a snap, and this is for a biceps muscle. So it's resisted supination. Then we'll go for instability. So to start with instability, you got to know the Byton hypermobility scoring. This is very important. And you got to know the scoring for the hypermobility, because some patients have hypermobility. So it may be a part of ligamentous laxity. So you will do the test for, you got to know the hypermobility scoring, which is, the score is from 9, passive dorsiflexion, hyperextension of the 5th metacarpopharyngeal joint, beyond 90 degrees, a position of the thumb toward the forearm, 2 points as well, passive hyperextension of the elbow beyond 10 degrees, passive hyperextension of the knee beyond 10 degrees, which is a recurvatum, and the patient, as in the picture, can reach the floor with his palm at the same time the knee is fully extended. So this is 1 point. So it's 9 points. And then we'll go for instability test. First, the sulcus test. So sulcus test is simply presenting an downward pull of the shoulder. And you can, as you see in the picture, you can see the sulcus sign on both sides, anterior and posteriorly. And then you have the apprehension, augmentation, relocation, release test. But of course, this test is very difficult to do it in the exam, because simply you might dislocate, and it's really not comfortable for the patient. But you got to have an idea. So this is the only test during shoulder examination where the patient is either sitting or in supine position, better to be lying flat on his back. So you'll start by putting the shoulder in 90 degrees of abduction, and then starting externally rotating the shoulder. First of all, the patient might, within like 40, 45 degrees of external rotation, will start to have apprehension. So you got to stop. Then repeat the test while putting, as in the picture, repeat the test while putting your hand anterior on the shoulder to keep the patient, give him sort of security, so that you can do external rotation beyond 45 degrees. Then you can release your hand while external rotation, the patient will do apprehension again. So I think this is not typical to be done during the exam. No one will ask you to do such an examination, but you got to have an idea about it. Then you finish your exam by the thoracic outlet, the 2 tests for thoracic outlet syndrome, the Apprehension Test, by putting the patient in sitting, putting your hand on his pulsation, extension of the shoulder, elbow, feel the pulse, rotate the head toward the side of the examined shoulder, deep inspiration, and this will cause hampering the pulse, and then release the position. The pulse will return to its normal. And the last one is the cross stress test, which is putting the patient in this position, which is abduction, external rotation. Keep it for 1 or 2 minutes. The patient will start to have some tingling and nervous manifestation. So just to summarize, the patient standing, let the patient stand. You can look, you will feel, as you said, the palpation, which is the AC joint. This is the most relevant. Movement, you will start with active range of motion, then passive range of motion. I'll go again for impingement test, the 3 tests within 1 move. And then I will do examination of the muscle. The most important for us is the rotator cuff. The other muscles, actually, we're going to give it separately in brachial plexus. But just to summarize, we have 3 muscles in the front, 3 muscles in the back, beside the rotator cuff muscles. We'll discuss that later. And then putting the patient in sitting position to examine the instability. Don't forget the Byton hypermobility scoring, especially if the patient have manifestation of instability. And then lastly, the thoracic out syndrome examination, which we have the vascular part and the nervous part. So this is a summary of the shoulder examination in my mind. Would you like to go for questions or go for elbow examination? What do you think, Hussein?
If there are any question, please ask now. Yeah, just unmute yourself and ask, please. Yeah. Okay, so I think no questions for now, so we can carry on and leave the questions to the end. Yeah.
For the examination of the elbow, it is much easier. However, there will be a little bit of change in the order. Elbow examination is usually for short cases. It's usually unlikely to have long case for elbow problem. In this situation, we're going to look, move, feel. So the order is changed a little bit. So first of all, we'll tell the patient to, it can be sitting or standing, better to be standing. You'll comment from the front by inspection, commenting on the carrying angle. There's usually average valgus angulation. You got to speak negative. So for instance, by examination, by inspection, I can't see any scar. There is no rheumatoid nodules, no Popeye sign, no lumps. Compare with both sides from the anterior part. Look from the back, look posteriorly. Elevate the shoulder, and this will be as well screening of the shoulder if there is any problem. Comment on the skin, scars, nodules, infracondylar recess obliteration if there is effusion. Look laterally if there is atrophy of the skin, if there is repeated steroid injection in case of lateral epicondylitis or tennis elbow. Then look medially and ask the patient to move. That's why we're going to move after inspection. Instead of going for palpation, go for movement. So ask the patient to bend his elbow and see the range of motion, if there is limited flexion, limited extension. Have a look on the medial epicondyle if there is ulnar nerve subluxation. Sorry. Supination and pronation, range of motion. Radiocapitellar examination by shaking the hand. You can do also supination and pronation. And then go for palpation. So for palpation, go from either medial to lateral or lateral to medial. We'll start by lateral. If there is tenderness of the lateral epicondyle, you will go for specific the provocative test for tennis elbow. If the patient do not have any pain on the lateral condyle, you don't need to do the provocative test. So feed the lateral condyle for any tenderness, do the provocative test if needed. Then anterior, you have the hook test for the biceps tendon integrity. Medial epicondyle for Gorfel's elbow. Again, if it's positive, go for the specific provocative test, which is actually flexion against resistance. In case, of course, the provocative test for lateral epicondylitis, it will be extension against resistance of the rest joint. This is a picture for the isosceles triangle. Of course, you know you should know that the isosceles triangle between the medial epicondyle, lateral condyle, and the recurrent should be equal, and in case of extension, should be straight line. The anatomy of the medial and lateral collateral ligament, you should know it by heart. The medial collateral ligament, you have the anterior bundle, posterior bundle, transverse bundle. Lateral collateral ligament, you have the annular ligament, accessory collateral ligament, radial collateral ligament, and of course the most important is the lateral ulnar collateral ligament, and this is important in case of posterolateral instability. Examination of the MCL and LCL is simply by putting the patient in flexing the elbow about 30 degrees. And of course, we know this is important to disengage the olecranon from the fossa. And then you'll do valgus stress test to see the integrity of the MCL. And of course, the opposite way around in case of lateral collateral ligament. Putting the patient, again, flexing the elbow 30 degrees, pronation of the elbow, and you can do the VAR stress test. In case of instability, we have also, again, apprehension test, which is difficult to be done and really painful. So the easiest way is just telling the patient to lift himself from the chair in case of posterolateral instability, which is a tear of the lateral ulnar collateral ligament. The apprehension test, which I believe is difficult to be done. So simply putting the patient supine, shoulder and elbow flexed to 90 degrees. The patient forearm is fully supinated, and the examiner hold the patient wrist and forearm and slowly extend the elbow while applying a valgus and axial compression force. Subluxation of the radius and ulna from the humerus causes a prominence posterolaterally over the radial head and dimple between the radial head and the capitellum. And when the elbow is at approximately 45 degrees of flexion, the ulna suddenly reduces. It's actually very similar to that of the knee, the apprehension test of the knee. And this is from my side, if anyone have any questions. Thank you very much.
Thank you, Hussein. That was excellent. So, so guys, any questions? We have plenty of time for questions. If anyone has any points he wants to clarify, I'm sure Mr. Hussein is more than happy to answer. Any questions? You can unmute yourself, because I'm now confused a little bit about the hands, which I think it is because of the viva. So if anybody has questions, just please unmute and ask. No one. So so maybe I will ask Hussein. So when I go to the exam, that was a bit of general. So do you have any advice? Like, I know that I'm going to the upper limb case, and I went in and I found shoulder case.
Yeah.
And he gave me a history that this patient, blah, 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 he has pain on his shoulder with some weakness. How should I approach this patient? So if it is short case or if it is a long case. So can you take us through these two, because we don't have much time either in the history or in the examination.
Yeah. So if you are going, for instance, to talk about long case, first of all, you have 5 minutes for taking the history. You have like 5 minutes to do the examination, and I think 5 minutes for the examiner, or 10 minutes. So you don't have plenty of time. So you got to have system of in your mind. For instance, first of all, for the history, you got to have in your mind how you're going, what are the questions, important questions. For the shoulder, you got to know the history in terms of handedness, occupation of the patient, the type of pain, is it referred or not, to see if it is like inflammatory, is it nerve problem, for instance, brachial plexus. So if it's brachial plexus, maybe you don't have pain, you have weakness. So this type of question is very important in terms of the history. In terms of the examination, you have a system of examination in your mind just to spot out. For instance, you will start to do passive active range of motion. So if the patient have limited or painful elevation of the shoulder, you have your mind 2 or 3 diagnoses. It might be impingement syndrome, might be rotator cuff arthropathy. You might have rotator cuff tear, or you have osteoarthritis. So this is in your mind. This is the most important or the most common diagnosis in the shoulder. So from
or
the
brachial plexus maybe, but this is completely different. Devil, monster.
Yeah. So we'll talk about the most common topics in terms of the shoulder pathology, like rotator cuff. So patient will start elevating his shoulder. It's painful. The patient cannot reach overhead activities. So now you have either impingement or rotator cuff tear, or rotator cuff tear complicated with rotator cuff arthropathy. You will do 2 things to differentiate with the clinical examination. So you'll do the impingement test. So they are positive. Okay, well and good. Go for external rotation. External rotation is limited. So you have probability that the patient have osteoarthritis versus rotator cuff arthropathy. Then you'll do examination of the muscles. You have supraspinatus. It's not affected. So if it's not affected, so it might be only impingement. If the rotator cuff is weak, supraspinatus, infraspinatus, so you have high chance that the patient have rotator cuff tear plus or minus rotator cuff arthropathy. So from the clinical examination, you got to be minded. Patient, you examine the shoulder, quick screening, inspection, palpation, you put your hand directly on the AC joint plus or minus AC joint arthritis. His range of motion is limited, above head, so he cannot do abduction over the head. He cannot do external rotation. So you have to diagnose in your mind rotator cuff arthropathy, rotator cuff tear, do the examination of the muscles. If they are not weak, so it might be impingement. If they are weak, so you have rotator cuff tear. Then you will ask the examiner, may I have X-ray? The X-ray will show everything. Might be calcific tendonitis, impingement, might be rotator cuff arthropathy, and then the patient, the examiner will ask you how you're going to manage the patient accordingly. So you got to be minded. This is the most important, the most common diagnosis in your mind. So you got to react according to what you see clinically. But after the clinical examination, within 2 or 3 minutes, you should have something in your mind.
I see. Thank you. So, and do you have, before we move to the elbow and do the same, do you have any specific questions, differentiating questions in the history, if you are faced with a shoulder case that you ask so you can differentiate between, it will make you reach the diagnosis or at least narrow your differential diagnosis?
Yeah, you got to have to take a proper history. For instance, you got to know when the pain started. You know how you got to know also the activities which is hindering the patient. He will tell you overhead activities. He will tell you weakness. You got to know if you have previous history of injection in his shoulder. So if you have previous injection in his shoulder, it might be impingement, rotator cuff tear. The pain is most important because it will differentiate from brachial plexus injury. Brachial plexus injury, usually the complaint is mainly weakness rather than pain. So this kind of question is important to spot what type of diagnosis you are heading.
Yeah, and what's your tip to differentiate, or at least to show the examiner that you are aware that it is not from the cervical spine, and actually it is originated in the elbow, that all the symptoms and all this, if the patient is complaining of pain in his shoulder. So anything that you recommend that we have to ask or have to do, or
usually if the case is shoulder, I think you'll not be distracted by the cervical spine. You'll have like a quick question if the patient have radiculopathy, have referred pain, have some sort of funny sensation in his hand, tingling sensation, this kind of questions, just to exclude any nerve root compression or like neurological problems. It will be a quick question, just to exclude it.
I see. Okay, so now moving to the elbow, just to cap or summarize our point. So again, I went in. Usually the elbow short case, it's very, very rare to find a long case for the elbow. So maybe we'll concentrate more on how to diagnose in maybe 3 minutes, diagnose and examine actually in 3 minutes or 3.5 minutes, because I need to leave 1.5 minutes for the questions. So any tips that to reach the diagnosis quickly?
I think because
sorry for the interruption. I think in most of these cases they offer you to ask the patient
1 or 2 questions.
Yeah, 1 or 2 questions. So also if there is any specific question you think that would be helpful, so we can tell our colleagues here.
Yeah, so in my mind, if there is elbow case, so it will be either post-lateral instability, or it might be, I don't think, maybe it will be tennis elbow, golfer's elbow. So I got to ask if there is history of trauma, history of elbow dislocation. This is an important question. It will just exclude if the patient have trauma, if have dislocated elbow. This is one important question for me. Second question will be if you have taken local injection or not. This will spot out if tennis elbow or not. I think this is the most important in the elbow. This is in terms of the history. In terms of the examination, as we previously showed in the clinical examination. If you have in mind a systematized way of thinking, just looking from the front for the carrying angle, letting the patient bend his elbow, look at the carrying angle, talk all the time negative. I mean, there's no nodules, there's no scars, there is no Popeye sign if there's biceps tendon tear. This is the way of thinking. Then you'll feel from lateral to medial if there is tenderness of the lateral epicondyle. So this is tennis elbow. Do the provocative test, hook test, medial epicondyle, and then examine the MCL and LCL. It's short case, and I think it will not be a big deal. Take care of the ulnar nerve, because it might be ulnar nerve subluxation. Simply by the patient bending his elbow, looking at the medial side, you can see the ulnar nerve subluxing from the medial epicondyle. So these tips might help you in spotting the diagnosis.
That's very excellent. And maybe a small tip from me, if you allow me. So be careful about when the examiner is telling you examine the wrist of this patient, but this is a very, very famous, tricky question or approach to the clinical examination of the elbow. So he will tell you, so it happened with me twice. Once it was synostosis, and he will just tell you examine the wrist, and then when you try to do the pronation supination, that will take you up to the elbow, or congenital subluxation of the elbow, and at the end it is rheumatoid hand. I think when I passed, the examiner was impressed that he told me examine the hand, and then I went looking at I just described the hand, and then I went to the elbow. So he told me, what are you doing? I said, yeah, because it is rheumatoid, and I have to make sure that there is no subluxation of the radial head. And he was happy about this thing. So maybe this is also always keep in mind, especially when he tell you the wrist, it is always, there is something about the elbow, most of the cases, or at least keep it in mind, not always, sorry. And if he told you the elbow, then think also about wrist. They are, because they are interconnected with in the pronation supination, so they come together. Yeah, so still, yeah. Anything, Hussein, you want to say?
Abdullah Gabriel is with us today, so
yeah.
Abdullah, how are you doing?
Yeah.
I'm fine, thank you.
Yeah. So welcome, Abdullah. So I believe no questions. Nobody's coming with questions. Any questions, please?
Can I ask one question, please?
Yes, please, Ghulam.
Yeah, just when I find in examination that there is a limitation of pronation and supination, so I'm worried that it could be proximal or distal. How can I differentiate that clinically, that this synostosis is proximal or it is the distal radioulnar joint arthritis or rheumatoid? How can I differentiate that?
Thank you, Ghulam. Yes, Mr. Ngigi.
Yes, I believe in synostosis clinically, I'm not sure if you can differentiate it clinically, but I think you can ask the examiner that you might need an X-ray just to differentiate between superior and inferior synostosis. Abdullah, would you like to add something? What do you think, Sam?
Yeah, I think it is. If you are allowed for history, then this maybe give you a clue, like when it started. Is it from childhood, or is it post-traumatic, and all these things maybe. So this can give you a clue, but at the end of the day, it is the X-ray, and I think just by telling the examiner that you are thinking about both options, then that will be the point. Yeah.
Great.
Okay, thank you.
You're welcome. Any questions, guys, before we go to the Viva?
I think Hani Salib is raising his hand.
Now, many people are raising their hands. So if anybody wants to ask, just unmute like Ulam and ask, please.
Hi, I'm just raising because of the Viva.
Yeah, I know.
Nice talk. Thank you very much.
Okay, so should I stop now the recording?